Yes, sir.
Yeah. Can we start now? Or
Yeah, there are students are coming in. We can wait maybe a couple of minutes,
no problem.
maybe
No
1 or
problem.
2 minutes, and we can
Yeah.
start.
Yeah.
Yes, sir.
Khadilkar sir is here.
No, not yet.
Girish, we
Yes,
have
sir.
nearly 50 attendees.
Yeah.
Students will join gradually.
Yeah. Yeah.
It's 8:36. Just I think 1 minute and I will start then.
No problem, sir.
So let's start then, Girish.
Yes, sir.
Yeah. So,
So again, I have to share the slides, na sir.
huh. So good evening,
Sir, sir has introduced.
dear all. Welcome to this fine evening program. And today we have Dr. Girish Soni, and you have heard him earlier also. Dr. Girish Soni is a consultant neurologist at Leelavati Hospital, Mumbai. He is also a associate professor of neurology at Sir J. J. Hospital, Grand Medical College, Mumbai. And Dr. Girish is a extremely talented neurologist, and he has special abilities to pick up the clinical science. And I'm sure you will actually enjoy his talk. So over to you, Girish.
Yeah. Thank you, sir. So today we are going to discuss some of the clinical videos, pictures, as well as some imaging and EEG. So the talk will be mixture of videos, cases, as well as images. So we'll go ahead with a little bit of rapid speed. So this young patient presented with 2 to 3 years history of clicking sound in the ear or a history of bilateral tinnitus. So as you can hear a clear cut clicking sound coming from the repetitive contraction of the palatal muscles as well as posterior part of the tongue and pharyngeal wall is involved. So this is idiopathic palatal myoclonus. Basically the palatal myoclonus is caused because of disruption of dentato rubro-olivary pathway, and this pathway is called as Guillain-Molleret triangle. So any lesion in this triangle can give rise to palatal myoclonus. If we get lesion, it is called as secondary palatal myoclonus, and many times it is without any structural lesion in the brainstem or cerebellum. Then it is called as idiopathic or primary or essential palatal myoclonus. In many cases of palatal myoclonus, we get inferior olivary nucleus hypertrophy because of denervation. So how to differentiate between these two entities? In symptomatic palatal myoclonus, we always get some structural lesion in the brainstem or cerebellum. Along with there will be some brainstem signs in the form of ataxia, diplopia, oscillopsia, dysarthria, cerebellar signs, and the palatal myoclonus persists in sleep. While in essential palatal myoclonus, most of the patient, almost all patients, they give history of ear click. In symptomatic, the ear click is present only in 30 to 40% cases, and essential palatal myoclonus disappears in sleep. Some of these patients nicely responds to sumatriptan, clonazepam. Second line drug like pacitan, lamotrigine, piracetam we can try. And the last resort is Botox injection. If it is idiopathic palatal myoclonus, the tensor valley palatini of the eustachian tube opening should be targeted. While in symptomatic palatal myoclonus, levator valley palatini, the muscle which is present behind the eustachian tube should be targeted. Now this patient, hypertensive patient presented with IC bleed. If you see this bleed properly, there are two things. Number one, there are small islands of small bleeds which are either connected to the major hematoma or separated from the major hematoma. And number two, there is hyperintense, more intense bleed, and inside it there is hypoattenuated bleed with clear cut margin in between these two. So this is called as blend sign, blending of hyperattenuated area and hypoattenuated area with clear cut margin, and this is called as island sign, and they predict the hematoma expansion. So once you see the first scan, once you see these changes, you can tell the patient relatives, look, the hematoma is going to enlarge. You can plan a repeat CT scan within 6 hours, within 12 hours, and many of these patients shows hematoma expansion. And in this patient, if the island sign is present, blend sign is present, our blood pressure control should be little aggressive. You should target the blood pressure 130, 140 systolic blood pressure rapidly, rapid control of the blood pressure. So within the cerebral hematoma, there is blending of hypoattenuated area, and this hypoattenuated area represent liquid blood, which signifies active bleeding, and areas of hyperattenuated blood, and this hyperattenuated area represent clotted blood. So blend sign predict the hematoma expansion with specificity and positive predictive value more than almost 90%. There is one more sign that is with the contrast that we all know, CT angio spot sign, where on contrast CT we see unifocal or multifocal contrast enhancement which are non-uniform, and they represent the site of active bleeding, the ruptured blood vessel. And again, this predict the hematoma expansion in IC bleed. So this 65-year male patient presented with history of shakiness of the leg while standing and some gait difficulty from last three years almost.
आपको
पैर में दिक्कत है,
पैर कांपता है
जी
2-4 साल से। कब कांपता है?
हर वक्त खड़े नहीं हो पाते,
क्या होता है खड़े होते हैं तो?
कांपता रहता है,
जब चलते हैं तब
तो
आराम होता है, सोते हैं तब
तभी कुछ होता है लेकिन पता नहीं,
लेकिन खड़े होते ही पैर कांपता है।
आपका खड़े नहीं हो पाते, नमाज भी नहीं पढ़ पाते।
अच्छा खड़े हो जाइए। चल के दिखाइए, वापस आइए, वापस जाइए, आ जाइए वापस।
As we can see very clearly while sitting, while walking, the tremors are not there, and the tremors or shakiness of the legs is there whenever he is standing. So this is orthostatic tremor or shaky leg syndrome, which is characterized by tremors in both legs while standing, and the tremors disappear partially or completely when the person is walking or sitting. Remember, the tremor can be present when person is walking. It may not completely disappear while walking. The classical age of onset is 50 to 60 years after that, and it is a sporadic in nature, can be sometimes associated with Parkinson disease. If there is underlying Parkinson disease, the tremors could be slow. Otherwise, the tremors of orthostatic tremors, they have a frequency of 12 to 18 hertz, very fast tremors. And the drug of choice in such situation is clonazepam. The other drug that you can try are pregabalin, gabapentin, even syndopa. If you do EMG or if you auscultate these muscles, the auscultation or EMG characteristically show a sound of rotor of the helicopter, and hence this is called as helicopter sign. So presence of helicopter sign either by auscultation or by EMG is pathognomic for orthostatic tremors. So this young female presented with 3-4 weeks history of progressive left hemiparesis. When she came, she had a complete hemiplegia along with history of seizures, and the MRI was reported as a glioma. So T2 hyperintense, T1 hypo, flare mixed intensity. There is no diffusion restriction, only some wall is showing some diffusion restriction, wall of the lesion. And this is the contrast. So contrast typically shows open ring contrast enhancement. So this is typical or characteristics of tumefactive demyelination. So this patient after thorough workup received steroid, and this is the image after three months of steroid, and she completely improved with steroid. So what is tumefactive demyelination? It is a variant of multiple sclerosis, and by definition, they are more than 2 centimeter in size. They can mimic a neoplasm, sometimes lymphoma on images, because both these things shows contrast enhancement, variable perilesional edema, variable mass effect, and areas of central necrosis. What we know about this tumefactive demyelination from case reports and small case series, they are a large lesion with little or minimal mass effect and edema. Many times they are misdiagnosed as a brain tumor, leading to unnecessary biopsy or resection. Even after resection, they can mimic a neoplasm on histology because they also show hypercellularity, atypical astrocytes, mitotic figures. In some instances, these patients after surgery undergoes radiation therapy also with a misdiagnosis of glioma or lymphoma. So what are the typical imaging findings of tumefactive demyelination? In 80 to 90% cases, they are solitary. In 10% cases, they can be multiple. In most of the cases, they are supratentorial and center within the white matter, gray white matter junction. By definition, they are more than 2 centimeter in size with minimal mass effect for that size of the lesion. And they typically shows T2 hypointense ream around the lesion. I will show the image of T2 hypointense ream. And in 50 to 60% cases, you get horseshoe, open ring, or broken ring contrast enhancement, which is pathognomic for tumefactive demyelination. Please remember 30 to 40 to 50% cases of tumefactive demyelination may not show horseshoe ring contrast enhancement. They may show complete ring contrast enhancement also. The corpus callosal involvement is rare with tumefactive demyelination, though can be seen in 10 to 20% cases. So presence of horseshoe ring contrast enhancement and T2 hypointense rim is characteristics for tumefactive demyelination. And this T2 hypointense rim surrounding the lesion, it is because of foamy macrophages. The macrophages which are reach again along with CD8 cells also. So macrophage plus CD8 cells both are infiltrated along the rim of the lesion. In 30 to 40% cases, just like multiple sclerosis, the lesions can show a central dilated veins. So central dilated vein can also be seen in multiple sclerosis, can also be seen in Ballo's variant, can also be seen with tumefactive demyelination. And such central dilated vein is not seen, never seen in neuromyelitis optica. Very rare with an mock demyelination. Now next case, we had a 27-year-old lady who presented with 10 years history of muscle cramps, started from both lower limb and spreading to all over the body without any relief for multiple medications. And typically these muscle cramps got precipitated with exertion in hot climate. So what are the causes of muscle cramps? The most common causes what we see in clinical practice are metabolic causes related to calcium, magnesium, dehydration, renal failure, hypothyroidism, neurogenic causes like root pathology, anterior cell pathology, or nerve pathologies, peripheral nerve hyperexcitability disorders like Casper positive syndrome or benign cramp fasciculation syndrome or hereditary cramp fasciculation syndrome, Sato syndrome, and some myopathies like metabolic myopathies or cramp myalgic variant of DMD or BMD, dystrophinopathies. So these are the various list of muscle cramps. On clinical examination, she had alopecia along with history of amenorrhea from last 6 to 7 years. Otherwise, no history of muscle weakness, no sensory deficit, no sweating, no history of myokemia or sleep disturbances or behavior problem, no diarrhea, joint pain or any skin rash. And on EMG, she typically had crampy discharges at rest. Her CPK, all routine parameters were normal. The only abnormality what we got on USG abdo-pelvis was hypoplastic uterus. So what is this? Any comment, seniors? Anyone want to comment?
If you want to comment, you can raise hand. Huh?
I'm not able to see anyone.
Okay.
Should I proceed?
Yeah, take it, Girish.
So this is Sato syndrome. One of the cause of cramps because of peripheral nerve excitability. So what is Sato syndrome? It is a typical triad of muscle cramps, alopecia and diarrhea. This patient not had history of diarrhea. Majority cases are described in Asia and Japan. It is believed to be sporadic and has an autoimmune basis. Typically young age group, common in females. They can have amenorrhea, hypoplastic uterus and ovaries. Diarrhea can occur because of carbohydrate and glucose intolerance. If the disease starts early in the childhood, they can have some skeletal abnormalities. They can be associated with some other autoimmune diseases like thyroid, myasthenia. And if you do skin biopsy, the biopsy can show lymphocytic infiltration. As patient develop alopecia because of that, the treatment is steroid followed by long-term immunomodulator, as it has a remitting relapsing course. So long-term immunomodulators are needed in such situation. Sato syndrome. So this young boy presented with history of 2-3 months history of progressive cognitive decline, decreased scholastic performance, and such problem from last 1 month. History of fall. So very classical hung myoclonus or slow myoclonus of SSP. Why it is called as hung or slow? Because these are the periodic movements or quasi-periodic movements that appears as a jerk followed by sustained position and then gradually melting to a static position. Hence it is called as slow myoclonus or atypical cortical myoclonus. And it is because of defect in the integration of the sensory motor cortex and basal ganglia thalamic circuits. And hence, in such situation, the SACP are usually not giant or large. It doesn't interfere with consciousness. It is exacerbated by excitement, action, may disappear during the sleep. And they have consistent correlation with periodic complexes on EEG. This slow myoclonus, they usually appears in stage 2, prominent in stage 3, may disappear in stage 4. They are usually absent in stage 1, where patient have subtle personality changes, behavior changes. Seizures and myoclonus starts in stage 2, or movement disorder, or cortical blindness, chorioretinitis, optic atrophy. And in stage 3, they become almost decerebrate or decorticate. And in stage 4, the cortical functions, it disappear and myoclonus also disappear, end stage. And this staging are called as Jabor staging. And there is diagnostic, there is one diagnostic criteria, Dicken's diagnostic criteria, which is important for Viva purpose as well as exam purpose. So out of 5 criteria, 3 criteria should be present: clinical, EEG, CSF, presence of measles antibodies, and definitive brain biopsy. So what's about this EEG? These periodic complexes are called as Rademacher complexes. They are stereotype, generalized, high voltage delta discharges, and these discharges are superimposable, very much classical superimposable, and they should be checked in monopolar montage ideally, or in same montage. And these discharges represent polyphasic or monomorphic delta waves, and they usually recurs every 3 to 10 seconds. As the disease progresses, the duration between these two discharges disappear. So if the duration is usually more than 5 seconds, then patient is in stage 1 or stage 2. If the duration between these two discharges is less than 3 seconds, usually the patient is in stage 3. You can grossly estimate the severity or staging of the disease on the basis of duration between these two discharges, Rademacher complexes. These Rademacher complexes or periodic complexes, they are of 3 types. The most common type what we see clinically in routine practice is type 1 discharges, which are symmetrical, high voltage burst of stereotype delta waves. The type 2 discharges, they are characterized by giant delta waves which are intermixed with spikes, rapid spikes. So they looks like fast beta activity. So periodic delta waves admix with rapid spikes, type 2. While type 3 is characterized by spike wave discharges, and these spike wave discharges are interrupted by delta waves. So normally type 1 is delta wave, type 2 delta wave intermix with fast spikes, and type 3 is spike wave discharges which is interrupted by delta waves. Why this is important? Normally we see type 1 most common, type 3 they are associated with worse outcome, type 2 they are associated with better outcome. You can tell the prognosis to the patient, or you can understand the severity of disease by seeing the EEG only. Okay, so this 6 or 7 year old kid presented with history of refractory intractable seizures from 2 to 3 months along with cognitive decline following onset of seizure. The EEG showed infrequent discharges from bilateral frontotemporal area, and this EEG is from sleep. So this is sleep recording. Sorry, I'm not having awake recording. I have in my laptop, but forgot to place. So this is sleep EEG. So these discharges are almost present throughout the sleep recording. If you look at these discharges, of course they are more prominent on the left side as compared to right. They are frontotemporal prominent, frontal prominent. If you see the amplitude frontal, so frontotemporal left more than right, synchronous discharges throughout the sleep. So this patient fulfills the criteria of CSWS. So CSWS is treatable childhood epileptic encephalopathy, characterized by triad of intractable seizures, cognitive decline, and presence of epileptiform activity, which is very prominent or present throughout the recording during the sleep, which is called as electrical status epilepticus in sleep. So what is ES? ES. So marked potentiation of sleep epileptiform discharges, almost nearly continuous, bilateral, sometimes lateralized, significant portion of NREM sleep, and by definition they should occupy more than 85% of the total duration of NREM sleep, though some authors suggest 80% also. It should be differentiated from Landau-Klempner syndrome, because in Landau-Klempner syndrome the all patients may not have intractable seizures, while in CSWS all patients have intractable seizures, all patients have behavior problem, personality problem, cognitive decline. All patients show CSWS on EEG, and in CSWS the prominent discharges are from frontal or frontotemporal area, while in Landau-Klempner syndrome the prominent feature is cortical deafness or auditory agnosia. 50% of these patients can have cognitive decline, refractory seizures. All patients may not show CSWS or ESES. And the prominent sleep potentiation of the discharges, they are from posterior temporal area or posterior cortical area, while in CSWS they are from anterior cortical area. The Landau-Klempner syndrome responds better to steroid as compared to CSWS. This patient, the age of this patient, what I showed, we work up thoroughly to with this patient. MRI normal, CSF showed mildly elevated protein. She received good dosage of steroid, valproate, levetiracetam, frisium, but seizures were persistent. There was partial response to partial response in terms of cognitive decline. We planned IVIG to this patient, but after thorough research or reading, we added acetazolamide to this patient, and within 2 weeks, within 10 days, seizures subsided, cognitive decline started showing improvement, and this is AJ after 2 to 3 weeks after adding acetazolamide. So acetazolamide can show a dramatic response in CSWS in terms of seizures, in terms of cognitive decline. So this is a good study where 6 child were included. 5 patients showed a subjective good improvement in terms of seizures as well as cognitive improvement. Acetazolamide can be useful in Landau-Klempner syndrome as well as CSWS. So we had 3 patients of CSWS. In all patients, we added acetazolamide, and they showed good improvement clinically, along with steroid, of course. Next video, this young girl presented with history of repeated episodes of laughing spells, almost 50 to 100 episodes per day.
Excuse me. ఇది కూడా ఇది
So just in 20-second recording, she got 3 to 4 episodes of laughing spells. Her MRI showed typically T1 hypo to iso lesion, button-like lesion sitting in the area of hypothalamus, and T2 iso to hyper, iso intense lesion without any contrast enhancement, without any calcification. So this is typical of hypothalamic hamartoma, button-like lesion sitting in the area of the hypothalamus. And this is classical gelastic seizure, brief periods of laughing or grimacing with or without subjective feeling of mirth. Usually the sensorium is preserved in such patient, classically seen in hypothalamic hamartoma, can be seen in frontal as well as temporal lobe epilepsy. This patient additionally can have complex partial seizure apart from gelastic seizure. This patient can have crying seizures also. repeated episodes, few seconds episodes of crying spell, which is called as diachrystic seizures. A best treatment is radiofrequency ablation of the hypothalamic hamartoma or surgical resection of the lesion. This young male patient presented with history of 2-3 year history of back pain, and on clinical examination he had a pyramidal signs in both lower limb. Any comment? Anyone want to comment?
Arachnoid web.
Yes, classical scalpel sign, arachnoid wave. This is one of the treatable cause of myelopathy or treatable cause of syringomyelia in the cord. Usually arachnoid waves, they are intradural band of arachnoid tissue that extend to the spinal cord and causing indentation on compression effect on the spinal cord. They are usually dorsal in location, usually seen in upper or mid dorsal spine, and the characteristically produces a deformity of the cord which looks like a scalpel, and hence this is called as scalpel sign. They are associated with syringes either at the level of the lesion or most commonly just above the level of the lesion, and this patient can develop progressive pyramidal signs in both lower limb with or without presence of evidence of syringes in the on the imaging. So early identification and release of this arachnoid wave by surgical lysis is the best treatment. So this is one of the treatable cause of the syringomyelia. A closest differential of such arachnoid wave is spinal cord herniation. Usually there is a defect, it is due to defect in the dura mater, it is in the anterior part, and because of defect in the dura mater, spinal cord herniates, usually seen in mid to lower dorsal area, and it produces a different deformity. If you see this deformity, if you see these deformities, they are definitely different. So please don't confuse cord herniation versus arachnoid wave on imaging. So these are the various images of the arachnoid wave, a characteristic scalpel sign. So 3 Tesla MRI SWI images of the substantia nigra. Normally because of nigrosomes, we get a signal on SWI cuts or T2 cuts, thin cuts in the lateral part of the substantia nigra. And this hyperintense signal disappears in Parkinson patient. So this is called as swallowtail sign. Absence of swallowtail sign is diagnostic for idiopathic Parkinson disease. So this hyperintense signal is basically because of nigrosomes, which are small clusters of cells in the substantia nigra. This young patient presented with history of 3 to 4 days history of altered sensorium, along with jerky movements of the limb.
नीचे से पकड़ो लेते हैं अगर वो बाजू होती है मूवमेंट
Very clear-cut Opsoclonus myoclonus syndrome, which is also called as Kinsbon syndrome or dancing eye, dancing hand-feet syndrome. What is Opsoclonus? Opsoclonus is involuntary arrhythmic conjugate multi-direction saccades without any saccadic interval. They are primarily present during eyelid fixation or while testing for smooth pursuits. They get precipitated on convergence. They even persist during sleep or even eyelid closure. While ocular flutter, they are back-to-back horizontal saccades with intersaccadic interval. If there is intersaccadic interval, we call it as a square wave jerks. So horizontal back-to-back eye movements, saccades with saccadic intersaccadic interval is square wave jerks, typically seen in Friedreich's ataxia, progressive supranuclear palsy. How to differentiate opsoclonus for nystagmus? So opsoclonus has both phases of same speed, while nystagmus is characterized by fast phase and slow phase. The causes of opsoclonus myoclonus ataxia syndrome are most common causes post-infectious, post-viral, or idiopathic. Sometimes can be paraneoplastic. In children, you have to think of neuroblastoma. In adults or elderly, you have to think of CA breast, lung, liver, even CA colon. What is the treatment? Immunomodulators. If there is underlying malignancy, you have to treat that underlying malignancy. What is the difference between opsoclonus myoclonus syndrome in children and adults? In children, the autonomic disturbances, the cognition affection or alteration of sensorium is rare. Cranial nerve affection is rare. While in adult, the altered sensorium, autonomic disturbances, cranial neuropathies are common. The children can have additionally ADHD-like, OCD-like features apart from opsoclonus myoclonus. While in children, the remitting relapsing course is common and hence we need long-term immunomodulators in children. While in adult, the course is usually monophasic if there is no underlying malignancy, of course, and usually this patient needs short-term steroid and you can stop the treatment. So please remember these points between the difference between opsoclonus myoclonus syndrome in adults and children. 2-year history of progressive gait difficulty and progressive generalized dystonia. A classical video. As we can easily make out from the video, patient is very much symptomatic for gait problem, for generalized dystonia in the evening time, and in the morning time after awakening, the disability is much less. So this is characteristic DRD, DYT5, Segawa syndrome, or Dopa-responsive dystonia. So why this sleep benefit is there? Because the dopamine production is maximum in the night time during REM sleep, and hence the availability or concentration of dopamine in the nigrostriatal pathway is maximum in the early morning. And in DRD, the presynaptic pathway is affected, while in other Parkinson diseases, the synaptic or postsynaptic pathway is more affected. And hence, such sleep benefit is classically seen in DRD. But please remember, the sleep benefit is more seen in earlier into the disease, and as the disease progresses, as the age advances, this sleep benefit disappear or decreases. And this sleep benefit can be also seen in 50% cases of part 2 genetic Parkinsonism, as well as in idiopathic Parkinson disease in 20 to 30% cases, because we know the dopamine concentration is maximum in the morning time. Hence, it can be seen in IPD as well as in genetic Parkinsonism, though classically described with DRD. So what is DRD? It is a usually autosomal dominant disorder, typically present in first decade or second decade. If it present in infancy, or if it is associated with mental retardation or cognitive decline, it is called as DRD plus. So onset earlier into the infancy, mental retardation, cognitive decline, it is DRD plus. If it comes in first or second decade without any mental affection or cognition affection, it is plain DRD. So it is classically characterized by diurnal fluctuation, prominent response to low dose levodopa, along with Parkinson features, pyramidal signs, and postural instability. The most common variant is autosomal dominant because of GTP cyclohydrolase gene deficiency or mutation. Some cases are because of tyrosine hydroxylase gene mutation or cyapterin reductase gene mutation, and they are autosomal recessive. There, it is more common in female. This female child, they have a short stature. The disease start from the leg dystonia. Never start or rarely start with the neck dystonia or with the cranial affection. MRI Tourette scan is usually normal. Why Tourette scan is normal? Because it's a presynaptic problem and typical marked response to low dose dopamine. In some cases, they respond to dopamine agonist, particularly in autosomal recessive problem. Those who respond poorly to L-Dopa, you can try a botulism toxin injections also for dystonia. Next, this female presented with this problem from last 2 years with some history of hyperactivity and aggressiveness.
हाँ बोले बुधवार को आ जाओ ऑफिस चेक करेंगे एडमिट करोगे हाँ बोले बुधवार को आ जाओ ऑफिस चेक करेंगे एडमिट करोगे फीवर हो गया तो जास्त होगी
दोघं तिघं हात वर करा समोर थोडं खाली करा ना मी डोळे शक्यतो माझ्याकडे बघत राहा
So index case as well as both of the sibling all are affected. So this is myoclonic dystonia syndrome or DYT11 mutation, which is an autosomal dominant disorder due to epsilon cycloglycan gene mutation. Typical age of onset is childhood or early adulthood. So typically starts with myoclonus. So myoclonus affect the face, proximal upper limb, rarely lower limb is affected. The myoclonus can be seen at rest, precipitated by action or exertion, and they are rapid, brief, and irregular, like a lightning, and hence it is called as tic-tac myoclonus. So tic-tac myoclonus is very classical of DYT11. Many of these patients develop dystonia, and dystonia is mainly cervicocranial. Writer's cramp can be early presentation of this DYT11 mutation. Writer's cramp can be isolated feature also without myoclonus. With the disease course, myoclonus and cranial dystonia can appear later on. In 10 to 20% cases, dystonia can affect the leg also. Many of these patients have psychiatric features also. The characteristic finding of this DYT11 problem is alcohol responsiveness, a good response to clonazepam, valproate, and 2019-20 there are many case reports, case series that prominent characteristic a good or great response to zonisamide. So start zonisamide 100 milligram per day. You can build up the dose to 300 to 400 milligram per day, and almost myoclonus as well as dystonia respond fantastically to zonisamide. So zonisamide could be a first drug of choice, should be a first drug of choice in 2020 in DYT11 mutation. If patient doesn't respond properly or inadequately to drugs, we can go for DBS of GPI internum. and almost 50 to 60% patient can respond to DBS. Known case of chronic kidney disease patient presented with history of altered sensorium, and this is characteristic MRI of uremic encephalopathy. And this is called as lentiform Fuchs sign because of metabolic acidosis, which is commonly seen in renal failure patient. So what is lentiform Fuchs sign and where, when and where it is seen? It's a bilateral symmetrical T2 or flare hyperintensities in the lentiform nucleus surrounded by more brightly hyperintense rim around the nucleus. It is seen in conditions where there is metabolic acidosis. The most common cause is renal failure. Can be seen in metformin toxicity in diabetic patients, methanol poisoning, non-ketotic hyperglycemia. It can be associated with cerebral edema or hyperintense signal in other parts of the brain, as you can see corona radiata, subcortical white matter, posterior cortical areas is also involved in this patient. If diffusion restriction is there, which is rare, if it is there, it represents irreversible damage. So whenever you are seeing MRI of renal failure patient and you see lentiform Fuchs sign, please look at the diffusion images also. If it is present, you can explain a bad prognosis to the relatives. So what are the components of lentiform Fuchs sign? So you can easily see hyperintensity in the lentiform nucleus, in a lentiform nucleus, along with more hyperintense areas along the border of the lentiform nucleus. So laterally, external capsule, medially, internal capsule, stem is edematous external and internal capsule junction, and there are again one more 4 along the internal capsule also. So it represents medullary lamina. So these are the components of lentiform 4. So let's see 3 EEG serially, which we commonly encounter while reporting EEG, and all 3 EEGs, they carry different significance. So this is 9-year-old child who presented with history of seizures. So typically it shows bilateral occipital delta range slowing lasting for 1 to 2 seconds. So what is represent? It represent orida, occipital rhythmic intermittent delta activity, synchronous, sometimes unilateral paroxysmal delta frequency in the occipital area. It is prominently seen while in hyperventilation and in drowsy state. It is seen in children with epilepsy, particularly absence seizure or idiopathic GTCS, sometimes occipital lobe epilepsy also. If there is occipital lobe epilepsy, it is seen unilaterally. If it is generalized epilepsy syndrome, it is usually seen bilaterally and synchronous. Sometimes it can be physiological without any history of epilepsy. In those child who have history of epilepsy, and if you see orida on EEG, it signifies good prognosis, a good control with an anti-epileptic drug. So if you see orida in a patient of epilepsy, so indirectly it will indicate good prognosis. Now second EEG, a patient with refractory epilepsy, the EEG classically shows left temporal, anterior temporal spike sharp wave discharges along with slowing, which is almost continuous. So left temporal delta theta range slowing that lasts for more than 3 seconds. So this is called as theta. So this patient classically had left MTS on MRI and history of refractory epilepsy. So what is the
So theta is rhythmic delta activity that lasts for. Are you able to hear me, sir?
Yes.
Hello,
Yes. Yes.
Rakesh sir.
Yes. Yes. Very clear.
Hello.
Yes, Girish.
Am I audible, na sir? Am I
Yes.
audible?
Yes.
Yeah.
Yes. Yes, Girish.
So theta represents rhythmic delta activity that lasts for more than 3 seconds and often associated with epileptiform discharges. It's predictive
epileptic form interictal discharges? If you don't get interictal discharges, it signifies underlying hippocampal sclerosis or underlying hippocampal dysplasia. So whenever you are seeing EEG of hippocampal sclerosis, please look for thyrida also, which signifies refractory epilepsy status. Now this is third EEG in a patient with altered sensorium. So you can easily make out a theta delta range slowing synchronously in frontal area. So this represents FIRDA, frontal intermittent or continuous rhythmic delta activity. So FIRDA is seen commonly in metabolic or toxic encephalopathy. So common occurrence of FIRDA is with toxic or metabolic encephalopathy. Sometimes if they are present unilaterally, they indicates underlying structural frontal problem. So the significance of FIRDA, THRIDA, ORIDA different. FIRDA, think of encephalopathy. THRIDA, think of temporal lobe epilepsy. ORIDA, think of generalized epilepsy syndrome or sometimes physiological. So next case, we have time now. This 32-year-old lady, symptomatic from last 3 years, loss of sweating from the limbs, along with heat intolerance and excessive sweating from the back, normal sweating from the face and neck, no any other autonomic problem, weakness, imbalance, sensory complaints or gallbladder complaints. And there was a history of dryness of mouth and heat intolerance. So this is a dry skin, and here you can see a pigmentation over the back because of excessive sweating. So we admitted her in a hot climate, and after applying a simple towel, you can easily see there is excessive sweating from the back area with loss of talc from the back area and very well preserved or absence of sweating from the limbs. On clinical examination, the all deep tendon reflexes were absent. Pupils were normal, equal, reacting to light. So this is classical Ross syndrome, which is a degenerative condition because of affection of the postganglionic cholinergic fibers, typically triad of anhydrosis, absence of deep tendon reflexes, and Aedes pupil or tonic pupil. The disabling symptom in such patient is compensatory hyperhidrosis and heat intolerance, as our patient also had. So Ross syndrome is postganglionic problem, sweating problem. Usually it is not associated with any other autonomic disturbances in the body, can be seen associated with Sjogren syndrome. The treatment should be targeted in view of reduction of the heat intolerance, avoiding excessive rise in the body. If the truncal or back hyperhidrosis is troubling, you can give subdermal subcutaneous Botox injection in that area to reduce the excessive sweating from that area. Okay. Usually there is no definitive role of immunomodulation till now for Ross syndrome. Classical image. So I want to add some points for central pontine myelinosis. The first change of central pontine myelinosis is on PET scan. The earliest change within minutes, within seconds of CPM on PET scan is hot pons. See, whenever there is CPM, whenever you are correcting hyponatremia and patient develop altered sensorium, you have to stop sodium correction, you have to start hypotonic saline. If the PET scan is available, go directly for PET scan. MRI usually don't show a changes within 12 to 24 hours. The earliest change on MRI that is seen between 12 to 24 hours is diffusion restriction. And the classical diffusion restriction is batwing appearance or trident appearance in the central part of the pons. After that, T2 hyperintense signal comes and flare hyperintense signal comes. The T1 changes may take weeks. And if there is T1 hyperintensity, that indicates slower recovery or incomplete recovery will be there. So please try to see all the images to understand the prognosis. to understand the treatment plan. Some of the trials or case series says you can use IVIG or plasma therapy for such patients also early. You should use plasma therapy or IVIG as early as possible within 24 hours, at the max within 48 hours or 72 hours. Not after 72 hours. No benefit of IVIG or plasmapheresis after 72 hours. The other changes that we can see in CPM is owl eye appearance because of sparing of the descending pyramidal tract and because of affection of only transverse pontine fibers. Owl eye appearance or face of piglet appearance. Face of piglet appearance, owl appearance, it will be associated with PSP-like features or prominent pyramidal features, prominent Parkinson's signs, and the recovery will be slow with owl eye appearance or face of piglet appearance. I think last few video, this young male patient presented with 1.5 to 2 year history of progressive lower limb weakness followed by upper limb weakness, and on clinical examination, typically he has a periorbital puffiness. If you look at the temporalis muscle, I think you can appreciate some hypertrophy of the temporalis muscle. And there is indentation of the teeth over the lateral border of the tongue, indicating macroglossia. Whenever you want to look for the macroglossia, look at the lateral border of the tongue and indentation of the teeth over the lateral border of the tongue, as well as calf hypertrophy. So periorbital puffiness, pallor skin, typical hypothyroid face or myxedema face, temporalis, tongue and calf muscle hypertrophy, as well as you can make out a deltoid muscle weakness and some hypertrophy of the trapezius muscle also, as well as infraspinatus muscle. And on clinical testing, you can easily appreciate delayed relaxation following deep tendon reflex. This has to ideally should be checked over the tendo-Achilles tendon, but can be seen over the on bicep jerk, and it is called as Waltman's sign. So Waltman's sign is again classical of hypothyroid myopathy.
नाम क्या है तुम्हारा?
संजय।
Easily appreciate formation of lump over the biceps muscle after a blow with a hammer. It is because of prolonged muscle contraction and delayed relaxation of the muscle because of delayed calcium uptake in the sarcoplasmic reticulum. It is characteristic or pathognomic of hypothyroid myopathy, but please remember, can be seen in rabies with severe malnutrition as well as hyponatremia. The cases of myelinolysis has been described with all these three entities. So this is a Hoffmann syndrome, which is a variant of hypothyroid myopathy characterized by weakness as well as hypertrophy of the muscles. The muscle hypertrophy is because of accumulation of glycosaminoglycans, ultimately leading to excessive deposition of connective tissue in the muscle, leading to pseudo-hypertrophy of the muscle. Some researchers also say there is a true hypertrophy of the muscle, apart from pseudo-hypertrophy. Usually in many of these patients, CPK level, LDH level will be elevated. EMG usually show myogenic potential along with fibrillation potential in some of the cases. Some of the patient can show neurogenic as well as myogenic changes on EMG. And typical treatment is hormone replacement therapy. And this patient takes few weeks to few months to show improvement in weakness. Some of the patient of Hoffmann syndrome can develop aggravation of the weakness after starting the L-throxine. The exact mechanism is not known. If they show aggravation of the weakness after starting L-throxine or thyroid replacement therapy, you can add a steroid. There are some case reports of aggravation and role of steroid in such situation. If the hypothyroid myopathy presents with hypertrophy in infancy or early childhood, along with some cognitive affection or mental retardation, it is called as Kocher-Debris-Semeling syndrome, which is childhood or infantile equivalent of Hoffmann syndrome, while Hoffmann syndrome is seen in adult. Okay. Now last, we can easily see T2 as well as contrast, T1 contrast in a patient of demyelination. This is a basically image of demyelination where alternate hyper and hypo areas are seen, and they are basically because of areas of demyelination and remyelination, alternate areas of demyelination and remyelination, and this is classical of Ballo's variant, onion bulb appearance. Usually this patient shows poor response to steroid. You need to go ahead with IVIG, plasmapheresis, or maybe nowadays rituximab therapy in such situation. Thank you.
Yes, Girish, so it was wonderful, and your collection of clinical videos and cases is actually amazing.
Thank you, sir.
Especially this Ross syndrome and this DYT11 family
Yeah, sir.
was fabulous. Ajay, one thing I just wanted to ask, you said this immunoglobulin in central
sir.
pontine.
Just a minute, sir.
Can you just elaborate?
Sorry, sir.
You said this in central pontine immunoglobulins can be given.
Sir, some of the case series and case report, they suggest there is some immunological basis behind the central pontine myelinosis. So with this immunological basis, we can go ahead with IVIG or plasmapheresis trial. But you have to hit the patient very early. You have to diagnose such cases within 6 hours, within 12 hours. If you delay, no use, sir, much.
Can we ask the comment of Dr. Kaul or Dr. Madhusudan, sir?
Yes, sir. Yes, sir. Yes, sir. Please, sir.
No, I agree with Girish that because there is edema there, and therefore, I mean, I don't know immunological basis. How can we think of immunological basis?
Sir.
Everything is osmotic. But there is edema there.
Osmotic changes. So maybe disruption of the blood-brain barrier along with some immunological basis.
Will give, but I don't know what is the basis.
Sir, there are case reports, sir. Means there are basis. Many of the senior neurologists, they also say use it. I think we had a lot of discussion for this. Sudhir Kothari sir and everyone.
No, steroids is okay, but what about IVIG? But I know people give IVIG, but I wonder that how it will help.
Sir,
it is sir mentioned. It is mentioned as a treatment.
Yeah, sir. But you have to hit very early, sir, within 6 hours or 12 hours, which we already have the diagnosis.
I have treated with the steroids successfully some patients. Madhusudan, what do you think? You have given IVIG in?
No, Subhash Kaul, I have not tried. But I think next case I will try IVIG or methylprednisolone after hearing what Girish has told.
And the other thing, Girish, I wanted to know that what is the supposed mechanism of this uremic changes which you showed in the CT scan, no? That uremic encephalopathy. What is radiologically? It looks quite fascinating. What is the mechanism of that?
Sorry, I lost you.
Mechanism of the radiological findings in uremic encephalopathy. You showed all that thalamus and the cerebellum and all that.
Sir, osmotic changes.
It's an osmotic thing. Correct.
Yes,
correct.
Sir. Yes. Sir.
Like Girish, it is thought to be due to the acidosis, second due to uremia, or the other conditions also produce acidosis.
Sir,
this particular
No, what does acidosis do? What does acidosis do to the neurons?
That I don't know, Subhash. But it is
osmotic changes, sir.
Yeah,
osmotic changes, most likely.
And these membranes, they are more susceptible for these changes. That's why more hyperintense stream along the border of the lentiform nucleus, sir.
Correct.
I think fascinating cases.
Yeah, very good collection, Girish.
Thank you, sir.
Fantastic. So I think we can close now.
Yeah.
And thank you, Girish.
Thank you, sir.
So what do we have next week? Again, Girish part 2?
Next, sir, we keep the long cases and then we alternate with these videos or methods of examination.
I think we have to alternate between Madhu and Girish. Then we need not read
Yes,
anything.
Yeah.
Okay. Thank you, sir. Thank you so much.
Fine, sir. Fine.
Good night.
Good night, sir. Good night.
Thank you. Good night.
Done, Girish.
Thanks, Girish. Fantastic, Girish.
Thank you, sir.